health supervision, setting a standard for CV health, was in 2005. And most recently in Circulation in 2015, it's really special reports really trying to target what are our research goals, what is standard of care, what should we be doing to really focus on the heart and optimize heart health. And so what these working groups came up with, one from a clinical standpoint, really kind of trying to refine and really standardize the guidelines of care, because there is still a lot of variability. But it's really still focused on early intervention and multi-specialty involvement. The research, really talking about how for every trial that's done for skeletal muscle, for breathing strength, every research aspect should have a cardiac arm in it, that we should be looking for cardiac endpoints in these trials, because many of them don't. And the reason why it's hard, because cardiomyopathy and heart failure that you can measure symptoms from occurs very late in disease. And if we're all doing our job right, you shouldn't be getting that, right? It should be the exception, And so that is why it's challenging to develop trials with heart failure in this disease model. But for everything that's being done, there should be focus of the heart. The cardiac care should be included into all of the research that's going on. This was sort of as an imperative, basically a call for researchers in the field. We're looking at, for every study that's done, that there should be, tissue stored, DNA stored, material stored for further research. And these are some of the questions that are still out there. How can we slow, reverse, prevent the cardiac disease progression? How do we determine who is at risk, say, for rhythm problems? Who is at risk for developing early heart failure and who is not? We still can't do that in the general heart failure population, but particularly in this disease, where at least we know the heart problem is caused by the same the same abnormality in the dystrophin gene, even if it's different mutations and all that. What do we do for women who are carriers? I don't know if there's any moms here in the audience who are actually carriers of dystrophin abnormalities, mutations, but we don't know the optimal care for that, except cardiomyopathy can develop. You should still be being screened proactively, typically it's about every 5 years or so. And again, prevention and being proactive is the key. So I think really, as Dr. Day said, our strategy to advance the cardiac care is really multidisciplinary collaboration. And involving everyone in research trials as much as possible, and really a full team approach. There are general pediatric heart failure management guidelines that were put out in 2014 that really review all of the research that's been done that's relevant to children with heart failure, multiple etiologies. And in this, importantly, there is a chapter on neuromuscular disorders, and that is what we're practicing from. That is what these guidelines, our care guidelines, are from. And the guidelines are weighted based on how much evidence there is to support them. So while there aren't, multiple clinical trials where we have 1,000 kids who take a medicine and 1,000 kids who don't, because this is still relatively a rare disease, we use the expert opinion, small center studies, and all to come up with these recommendations. And so the key thing is that medical treatment of heart failure, meaning initiation of ACE inhibitors, beta blockers, right, cardiac specific treatment, is initiated at the onset of echocardiographic evidence of ventricular modeling or dysfunction. So what that means is that once that there is abnormality detected, either on echo or on MRI, that is the consensus of the appropriate timing to be starting medications. Now, there are some centers who start medications much earlier, right at the time of diagnosis, in the hope of trying to prevent it. But just to know, while that likely doesn't cause any harm, at this point in time, that is not established that there is benefit. And so the Pediatric Heart Failure Society, these are nationwide recommendations, is to be at the onset of any changes, that is the absolute time to be starting things. Now, whether things are started earlier or not, we don't know that there's any benefit. Even though, yes, you can pull up one study here with 20 people had some benefit, 10 people there, but scientific review of these types of trials, that this is where we're at this point in time. There's a question.
Would you start those medications prior to symptoms?
Absolutely prior to symptoms. And that's the whole point of the surveillance, echoes versus MRI. That you definitely want, if you start to see the heart just a little bit dilated, a little bit not normal, or if there's a little bit change in the squeeze of the heart, that is the point where, okay, we see the process has started, right? And that's very variable. Typically we start to see things maybe early teens, I would say, most commonly, 10 to 12, 12 to 14. There are also some older kids, though, who are still looking fine. And so we try to balance the exposure to different medications and all that. So absolutely, you want to start before symptoms develop. Symptoms of heart failure, the heart's not keeping up. But you kind of want to get a middle ground to say, well, okay, at least I see that the process has started. It's not causing any trouble right now, right? But kind of right at the time, say if you're diagnosed when you're age 2, have a very early diagnosis, that's likely too early. So that's sort of where we weigh all those factors. And again, everyone is an individual, everyone is different, every family is different with their views on medications and all. And so, but these are sort of the standard guidelines. Any other questions on that? Because I know this comes up a lot.
Echo versus MRI?
Yeah. So again, that sort of comes down to person dependent and center dependent. So the having an echocardiogram, typically you can get the information that we're looking for, the size and function of the heart, relatively quickly. You don't need an IV, and the results are available right away. I can pull up an echo in the office, 30 seconds after you're off the table, and they're very easily accessible. Now, however, sometimes you don't get the best images from it based on your body habitus. So where cardiac MRI comes in, you get a lot more detailed pictures. If you want to get more information about is there scar tissue in the heart or not, say if you're trying to decide on a therapy or not, or if you're not clear with the echo images, is the heart, is it really normal or is the function a little bit down? So the MRI is much more specific for looking at that. However, at least in the past, it can take a lot longer. It may not be as comfortable sort of lying on the table for a longer time. And the processing time of it, it's not sort of real-time accessible. At least it hasn't been. And that's a protocol that we're actually starting here at Lucile Packard of trying to make the cardiac MRI protocol much more convenient, shorter, focused, so that we can get as much detailed imaging as possible, but in a way that's not too uncomfortable for the patient and doesn't take a long time and we get the information quickly. So actually some of you may be approached to sort of, we're doing a comparison, sort of doing an echo and an MRI in the same encounter, and you tell us, how does it work for you guys? And from the medical side of it, we're judging the information we get from each. We have some new docs working on that. So it depends what you're looking for. Dr. Day.
Do you have a sense of what features might be reversible on echo and MRI, which are really indicative of more permanent change?
Yes. So I think once you start to see scar tissue develop in the heart, this fibrosis, the studies of, again, everything of which we know is really based on adults with different types of heart failure. And in those studies of using these drugs, you don't typically see a reversal of that fibrosis. But what you can see is if the heart is dilated, it can get a bit smaller, right? If the squeeze is weak, the squeeze can get stronger. That's with some modifiable factors of disease, with some of the medications that's used. But again, it's very just, we don't have good targets other than just the gross abnormalities. Can we make the heart squeeze harder, and is the size getting abnormally enlarged or not? It's those measurements that have been the targets of the drug trials that we have. But the thing is that it depends, we can't reverse until we can put dystrophin back in the heart. That stimulus is going to be there for the lifelong, that your heart will always be working with the absence of dystrophin in it. So everything we're doing is still trying to mitigate that response, versus say if you've had heart surgery or something and you're recovering from it. So it depends. All right, I don't want to go over time here. And again, just other recommendations regarding the use of steroids. I think it's been pretty established that should be considered for boys to try to delay cardiomyopathy as well. And important, what I mentioned with regard to the use of mechanical circulatory support, consideration of cardiac transplant, really should all be made on a case-by-case basis, looking at all of the comorbid conditions that limit post-transplant survival and good outcomes. So it used to be years ago that this was a contraindication. One, we didn't have any devices, long-term devices, and it wasn't even considered for people with neuromuscular disorders. So just giving you a little bit of historical context that everything is now on a case-by-case basis. So I will end there. And again, talking about the heart, it's scary, I think, of looking ahead and sort of knowing that, am I going to have problems with my heart? Or what am I going to do if my child has problems? But really, these are incredibly exciting, times in the field of heart failure and sort of insight into how the heart muscle works, of what tools we have in order to support it. And so I think that, I would be very hopeful, very optimistic that the field is being pushed, as I said, by all of those adults, who develop coronary disease in different models. But everything from that population could be learned and applied here, as well as all of the advances that are in progress with different, targeting the genetic change in DMD and working together with everything we know about cardiac function, how to support cardiac function, different heart failure medications that are coming out, and then working together with medications and interventions to support muscle health. I think that the future is very, very hopeful, and with lots and lots and more options for really, maintaining good cardiac care in the setting of DMD. So that's the message I really want to leave everyone with. And just prevention and being proactive and looking for it and follow up, that is the key. I'll leave there. Thank you.